Hi, everyone. My name is Richard Appiah from the University of Ghana, and my talk is titled The Inspired Life Program, a Development and Evaluation of a Multi-Component Positive Psychology Intervention for Adults in a Low-Income African Context. So a wealth of research, including several meta-analysis and systematic reviews, shows that positive psychology interventions can enhance subjective well-being and reduce negative affects such as depression and anxiety in both clinical and non-clinical population groups. Yet in sub-Saharan Africa, mental health research and interventions have focused primarily on treating psychopathology. Although efforts to treat mental disorders are important and laudatory, a considerable proportion of the population live in rural, socioeconomically disadvantaged settings, either languishing or experiencing moderate mental health, and at risk of developing mental disorders, and yet have limited access to mental health care. A recent scoping review of positive psychology interventions in Africa shows a limited number of studies, mostly conducted in South Africa with urban population groups. There is a growing need to translate psychological theories and research findings into health behavior change and strength-based intervention programs that are tailored to the needs, capacities, and circumstances of the local population group, and that can also be administered by local volunteers to a large group of participants. Well, we took up this challenge and set out with one question. Can we formulate a group-based multi-component positive psychology intervention for rural poor adults that can promote positive mental health, build resilience, and increase vocational productivity? Guided by the Medical Research Council's framework for developing and evaluating complex interventions, we drew on constructs and principles of positive psychology and cognitive behavioral therapy and followed a 7-step iterative community-based participatory research approach to develop the intervention program, which we call the Inspired Life Program. The first step was to identify relevant theories, models, and previous interventions that support the promotion of positive mental health of vulnerable population groups. The second step involved specifying the program outcome, performance objectives, and determinants of change. In the third step, we defined the content, the themes, the structure of sessions, and the implementation strategies. The fourth step involved consulting with selected members of the communities to appraise our defined content, structure of sessions, and implementation strategies, and to solicit their views to revise them. In the fifth step, we simulated a draft session of the program with a group of psychology graduates in a group session to practicalize and identify possible challenges with communicating the session themes and to evaluate the structure of sessions and strategies for implementations, and again to revise accordingly. For the sixth step, we submitted a manualized session program to 3 subject experts to evaluate the program in terms of its feasibility, acceptability, practicality, and potential impacts. The last step involved revising and pilot testing and refining the program. The final intervention component included a 10-session, 2-hourly, once-weekly manualized program aimed to equip participants with knowledge and skills in meaningful and purposeful living, self-acceptance, kindness and compassion, personal growth, goal setting, time management skills, problem-solving skills, as well as cognitive restructuring, that is how to identify and challenge unhelpful thinking patterns and replace them with positive ones. Using a quasi-randomized control trial design, we randomly allocated 84 participants from 4 rural poor communities to intervention and control conditions. The intervention group participated in the 10-session, once-weekly, 2-hourly program facilitated by 2 psychology graduates and supervised by a psychologist. Both groups completed a battery of mental health and well-being measures, including the mental health continuum short form, at pre-intervention, immediately after intervention, and 3-month follow-up. The research team previously translated and validated all 6 measures into Twi, which is the most spoken Ghanaian language in which the sessions were held. We applied hierarchical linear modeling to evaluate whether the intervention was effective. We also established the prevalence levels of positive mental health over time using Karuki's categorization. There was a greater improvement in positive mental health with a marked reduction in symptoms of depression in the intervention group compared to the control group. Immediately and 3 months after the intervention, there were also larger increases in the proportion of flourishes in the intervention group compared to the control group, again, immediately and 3 months after the intervention. Our findings have a few implications. The first and third Sustainable Development Goals seek to reduce poverty and promote good health and well-being. Well, because poverty is a risk factor for poor mental health, interventions designed to promote mental health and build resilience in the low-income context of sub-Saharan Africa should be multi-component and should necessarily also aim to teach psychosocial and life skills, such as goal setting, problem-solving skills, time management skills, to equip participants and help them to take advantage of these skills and available resources, of course, in addition to the components intended to promote mental well-being. Another important conclusion from our study is that group-based positive psychology interventions are feasible and can bolster positive mental health, buffer against psychopathology, and teach psychosocial skills to people living in rural poor communities in sub-Saharan Africa, who are often neglected in mental health interventions and where mental health is still heavily stigmatized. Again, our findings demonstrate that the better way to minimize the prevalence of common mental disorders such as depression in the long term is to identify and intervene at the general non-clinical population level. We strongly recommend a multidisciplinary collaborative efforts in designing context-tailored, strength-based and positive interventions that support vulnerable population groups who are either languishing or experiencing moderate mental health into flourishing. Overall, we learned that the development of strength-based positive psychology interventions and the practicality of methods to promote mental health in rural adults are feasible and have important policy implications for mental health and social care in sub-Saharan Africa. We would like to express our appreciation to the following individuals and institutions. Thank you for listening.